and a very warm welcome to our webinar session for an important topic. Today, we are going to have an interesting conversation on EHRs, the way EHRs have evolved and how we can look to bring in improvisation using documentation intelligence. Before we get moving, I would like to do a quick round of introduction. I am Rakesh Talreja. I am the head of Healthcare Business Unit for KANINI. With me, I have the honor of hosting an esteemed guest, Rosalind Beam. She has graciously accepted our invitation to share her views and expert opinions on the subject. Rosalind comes with a wealth of experience and expertise in this area. Along with the experience and expertise, she brings in a great combination of creativity and modern outlook to the delivery of healthcare. Rosalind is a strong believer that healthcare strategy should be consumer-centric. This is where we at KANINI connected with Rosalind's beliefs. As a business unit, we strive to devise solutions while keeping the patient-centric journey at its core. Adopting a consultative approach, backed by our domain expertise, we strive to deliver engagements across the spectrum of the patient-centric journey map. Without waiting any longer, I would like to introduce my honorable guest speaker for the session, Rosalind B.
Thank you so much, Rakesh.
Sure.
So I'm just to kind of add to yours, and you're exactly right. And why I'm here today is because of my beliefs in consumer-centric. So if there's any opportunity to be able to share knowledge that I've gained over the years, and just through experiences on both the provider side and the payer side. Today I do work as a technology solutions leader for a large payer, and that particular thing has allowed me to grow my knowledge in both EHRs and how document intelligence can kind of impact that. So,
Certainly, yeah. Thank you. Thank you for being here. My team, on behalf of KANINI and my team, my leadership, we really appreciate your presence here and you taking the time to spend this valuable inputs and sharing your ideas.
Certainly my pleasure.
We are going to spend the next 40 odd minutes to go over several critical aspects related to EHR. Now, given the vastness of the subject, we have limited our discussion on the following three topics. History and current state of EHRs. What role can documentation intelligence play in modern EHRs and EHR interoperability? I hope that in a way will give us productive utilization of our time. So if you're okay, we can get going with our agenda.
Sounds perfect.
Okay. What is EHR in general? How has it evolved? You've seen it evolving in your vast experience. So give us a view to that, please.
Thank you. That is a very, and I think it's critical. We always know where we've been to be able to get to where we want to be, right? And so EHRs basically have evolved significantly. They actually started in the 1970s, based off of a mandate by the government for veterans. And so it started in that area. And then started growing in hospitals in the 1980s. And when the initial ones were basically built, they were only built for that purpose. They were built to document for a task and to speed up workflows, whether it was for rooming a patient or piece like that. And so the modern day EHR has evolved from just being a separate piece of software where the doctors documented in one and registration and patient scheduling was done in another system. So now you'll see EHRs, and they focus on the EHR part, but it's actually a combination of a practice management system or a AR system if you're in a hospital. Many across the country right now are large integrated healthcare systems, but where people are needing help are the smaller groups, ones that are not basically associated, and specifically those in primary care. Because if you think about an EHR, it's a chain of events. It starts with that patient wanting that access to start off with, right? So then they call and they request a service. You have your whole registration part, and then they come in, they get all their documentation is basically captured, a new patient visit gets scheduled, they get through that process. Before the provider even starts their physical documentation, the nurse comes in, sees that schedule, basically comes in and brings that patient and has to collect a lot of data on that member. on that particular patient. And as they move forward, now the provider comes in. And the providers, remember, is changed from writing 3 scribbly lines in a paper chart to then having to dictate. That was the fastest way because they could just talk the way they wanted, and then people had transcriptionists that documented it, put it into what was called an EHR at the time. Today, they build it up a lot of different macros and forms and things so that you can capture data. And I know a subject we're looking at basically is you capture a lot of structured data, but you don't necessarily capture a lot of the unstructured data because it's in nodes that might come from different areas. And so different things have basically driven or guided physicians in healthcare to be able to start to manage that unstructured data, which is basically 90% of the data that's basically collected. So if you think about it, in AI in 2021 was a $6 billion business. People were investing in healthcare AI alone, and it's expected to get up to 10 times that by 2027. So for us to be able to drive that, you ask the question, what's driving all of this, right? What's driving that change in EHRs and why EHRs are so powerful? First of all, there's hundreds of them out there, right? There's some top ones that we all are quite familiar with. But the key driver was we have to improve patient outcomes, right? Patients want that service. How do we start to manage that time between the time, that little 10 minutes that they're seeing the doctor, and all the rest of their life, from the visit to piece. So I'll stop there just for a moment to see if you had some kind of backup questions.
Yeah, I mean, thank you. I think so. That's insightful. You did touch on visit documentation and some aspects of disease management. Now, value-based care is something that is the norm. I mean, that has to be the way healthcare has to be delivered. How will EHRs play a part while determining what value are we delivering to our patients, the value-based care aspects of that?
So EHRs as a whole have already started that. Very good question. And that's really been one of the key drivers because physicians and groups are introducing or engaging into what's called risk contracts. Mm-hmm. There's some where they assume part of the risk, some where they do all of the risk. Mm-hmm. But even CMS and Medicare started paying, and there were a number of different programs that providers could get part of. And so they had to be able to turn that data in. Mm-hmm. But all they had was claims data, right? Yeah. So claims data is only limited to the data that went in and the provider put in. And so EHRs play a role in trying to help capture that data or improving that capture. So from a value-based piece, you're looking at kind of 4 components with that. You have your patient care piece. That's the piece that we're really starting to get to because we know as part of our expense for the country as a whole, healthcare is extremely, so we don't have the same types of outcomes even though we spend this much money on healthcare. And so the thing is how do you coordinate that care? If I'm a primary care doctor, I check things. I don't really look. In the past, you didn't. You just dealt with that piece. You came in to visit, talked about the person's farm, how they're going, and went on to the next visit, to your next patient. And so you didn't, when you did a referral, for example, I see you're, having your blood sugars up. I better refer you to endocrinologist, for example. Let's check that out. But there wasn't a follow-up in that. But value-based care, you provide and you put in systems into play. And so that's why it's kind of critical. So the EHR can help you improve those workflows and improve that quality of care and really start to get that data that you need to measure it. So that's what you need. If you don't have the data, you're not going to be successful. And most providers, when they first signed it, they didn't get anything. And it's really based off of medical expense ratio, and you meet particular quality measures. And if you don't, you're not going to succeed in that.
Well said. And I know you touched on the AI adoption and adoption. You said it's going to, the investment is going to go tenfold in the next few years. How about the adaptation and the adoption in the health systems, more specifically the smaller physician groups that you called out?
Smaller groups will, when they look at EHRs, if you look at some of the top 5, they're cost prohibitive, right? For the small doctor, they have some options, and so they look at, if they're going to look at a cloud-based option or a newer system, but they want to be able to communicate. If they're a primary care doctor, but all of their specialists that they refer their patients to are on another system, they need to be able to connect to that patient. And so when you're looking at systems, you want to make sure that they have more than just the standard out-of-the-box type products that an EHR had back in the 1990s. What you need now is the population health. You need to be able to accept files. You need to be able to take those files and be able to glean key structured data out of them, such as a PDF lab result or a paper scan document. And so providers groups are basically utilizing AI as that, especially for predictive analysis, being able to manage that and manage their particular population for things, for disease control, like COPD, diabetes, asthma, those types of things.
And that's where I believe you mentioned the cost aspects of it. So solutions which are intrinsic to the system yet cost effective will be the key. That's how I see it.
Correct. Yeah. And so many of it's, like I said, it's going to be a $64 billion business. So it's not just the AI, but it's reporting that to organizations such as DH.
Yeah, correct.
And Department. Yeah.
We just called out our common belief in terms of consumer-centric or patient-centric journey, correct? That's what should be visible to caregivers, and that's a challenge.
So what you need from a provider perspective, and for the caregivers, is it has to be a coordinated effort. And those provider can look at a health system that they refer to. So if they're referring to a health system, sometimes that system will host them on their system. And or they can subscribe to a software, and do the SaaS or that type of piece. And so that helps that provider. But if they are able to learn that piece and enhance their EHR to that component, that would be key.
Got it. You did talk about the data elements, but what should be the key metrics of EHR to be considered before looking at solutions or any custom platform or COTS platform to be adopted?
Well, the first thing is you got to be sure they're certified. They have to go through a rigid certification process, which with the government, and be able to be certified, which tells them that they've met the security requirements, which are key, right? You're dealing with PHI, you're dealing with some major pieces of information. So you would want to ask that, especially if it's a newbie, check their referrals, check to see what they're doing, check to see if there's a beta site type piece, but assure you got the security, assure how do they bring in records from other entities and how can you communicate. Communication, 84% of patients, the consumers, said that they have dissatisfied visits because of the communication, the follow-up, the pieces of that. They don't feel they have that opportunity. So you want to assure you have something within your system of how do they manage it. Not only the communication and access, what do they have for a patient portal? How easy is it to navigate? Can you see it on all types of applications? Most people are carrying around their cell phone. That's the mobile device. And that's been the hardest transition for healthcare because they're not doing it on laptops. So the big things, however they're managing communication, how are they doing the population health piece, right? And are they able to predict and manage, from that population health? You're also looking at the items for a value-based contract. If you have any risk contracts, what are the metrics that they're using to help guide you to that success? Don't wait till Q4 to say, hey, these 1,000 patients are out of compliance and now you're not going to meet your goal. Have a plan or a strategy within your EHR that notifies you in advance, whether it's through insights.
So in a way, provider contracting, network contracting comes into play, in that sense.
Correct.
Okay, got it. Okay. You did talk about population health. That takes me to an important topic. It's a vast topic again, SDOH. And I know SDOH can be another session altogether. Maybe we'll do it some other day. But if you can just touch saying how are providers accounting for SDOH, mental health, and health equity while determining how should they set up their EHRs.
SDOH is basically one of the other key drivers, which value-based reimbursement, as they got into it, they found that some of the components of social determinants of health, those pieces like the economic stability, do they have not normal questions that you would ask, right? In a health setting, you'd ask, how are they feeling today? You don't ask them, do they have a steady job? Has anything happened to your work? It's your husband pieces. Education. And it's not just strictly, do I have a master's degree? It's basically access to education. Where are they getting their information? And so SDOH is looking at that, the young, very young age part of that. And then the big one, healthcare access. Healthcare access, not only access, but quality. How far do they have to travel to get that quality type of care? Do they have access to healthy food? Supermarkets, are they in a healthy food starved community where it's just they can't get to it, or they don't have transportation, just simple things like that. And then where they live, their neighborhood, is it safe? Do they have, and then the final one is things we don't think about, the social community. That really became prevalent during the whole COVID-19 pandemic because people were isolated and they found where, as you mentioned, mental health, where they have. And so one of the questions is, if you're looking through that piece as a provider, then you say there are studies and groups that are happening across the country. There's a group in Wisconsin, Data Care, that actually is participating in a program for the global health team. And what it is assessments. And so if you're looking at EHRs and where there may be opportunity, is better capturing that assessment. How do you do that? Medicare wellness visits are something that does that. They ask about falls, things like that, but it doesn't get into some of those other dynamics. But that sometimes you want to be able to capture and structure data so it can be mined and sent to these other industries. So overall, one of the interesting points that I have or found was there is something through DHS that they do every 10 years. So in 2020, they define what is going to be the health strategies for the next 10 years. And so there's a whole plan or strategy out there called Healthy People 2030. Whoa. And there are 355 goals that are attached to that. Of that, it's under health conditions, health behaviors, populations, settings, and systems. Guess what number 5 is?
SDOH?
SDOH.
Okay. So it is worth its while to get into.
So you get into that, and what I would recommend is to have, if they have somebody dedicated in their data mining or even in their care management, is to understand, and most organizations have probably taken that deep dive into understanding there are 34 of those goals of that 355 that are attached just to the access part of SDOH. But the fact that it's a key component of that, so it's very interesting to basically, so it has been a critical driver as we move up. Another interesting fact is about 68% of consumers of healthcare have at least one SDOH issue.
68.
Challenge.
That's a huge number.
So, but.
You did touch on these things, and that in a way takes us to the second topic which we were talking in terms of ruling the unruly. How do we bring in the unstructured data fitting into the structured? Because a lot of what you called out is in a way unstructured data which may not be getting captured into the EMRs or EHRs. And how do we capitalize on that? What current challenges in EHRs related to unstructured data we can think of when we are looking at the broader context as well as the current EHR's concerns? What would be your opinion on that?
So AI as a whole has become very prevalent within healthcare. And one of the key areas is in documentation. And we will talk about that when we get into Simple FaceTime, but it is one of the key things that it's used for today. And that's being able to capture some of this unstructured data putting it into a medical and then gleam it out with the machine learning and even extending that into using natural language processing to be able to pull that data out. But that is just expanded in 10 years. The amount of data has tenfolded along with unstructured data, kind of what we saw when we even talked about AI use and how it's being done. And it's really because of that, things like that, healthy people and people trying to, and the organizations trying to improve our overall healthcare piece of it. But the key part from unstructured data, about 90% of the data today that's captured, up to 90%, is unstructured, depending on the level of sophistication that those groups are carrying and what their groups are doing. So even just trying to capture some of those dynamics of, just because you do an assessment, if it's a questionnaire, if that questionnaire is not incorporated into the medical record, it's not going to help you. So, and if you're changing EHRs, which many large groups are, and they're changing, is how do you convert all of that unstructured data that you have into your system to make sure you populate, and it's just not brought over as an image for the provider to view, because that's really the critical nature, is they need to have access to that information.
And that was what I was going to ask. How can one focus on taking unstructured data and feed into structured data? That's where I believe documentation intelligence can play a critical role. What would be, your experience or insights, given that you are now doing a lot of technology work in that area?
Yeah, so documentation intelligence, as you know, does involve the AI and the deeper learning of seeing how you can basically utilize that machine learning to be able to help diagnose that piece. But if you're just a component of getting from the unstructured, you're doing that today with diagnosing mammograms, diagnosing CT scans, and things like that. So it's assistance, robotic surgery, those types of things. But when you're looking at that, these are now becoming to the fact that we get back to the cost, right, for some of those groups. Many larger groups have a whole document intelligence department to basically where they're looking at these mass parts of data and being able to pull the data out. Right now, physicians and groups are focused on how do they improve that ultimate outcomes of those patients, and that's what you're trying to do. There's a study that was done that showed or proved that adding unstructured data to structured data for predictive analysis proved more than a 95% success rate versus 65%. I'm not exactly sure, but there was a big jump, and it just demonstrated the importance of transitioning that to the unstructured data to structured, and the mechanisms to use that. And it's really the NLP, the natural language processing, which takes that. But what's the challenge of that? As we know, part of that is getting into how different all of the EHR systems are and basically how they utilize them.
That brings me to my next question in terms of data enrichment. Do you have some examples of use cases that the current system handles, and some examples of future use cases? I think so you touched briefly on those, but maybe in terms of use cases or examples that we can take as potential use cases.
So I think from the biggest potential right now is eliminating administrative burden. So basically from those providers, and basically that is not only from the documentation piece, we kind of talked through that. You don't have to get to the expanded part of the top of the line, which would be basically having something within the examining room with you that records everything that's said between you, the patient, maybe another caregiver, and then utilizes the document intelligence, whether it's machine, and they start to create not only the medical record, but they also pull out a lot of that unstructured data and get it organized into that piece. That's the big thing. So the first thing we have to do is from that, and that's true for order taking, and it's true for any of those, the billing, the coding, and those types of pieces. There's artificial intelligence. It's been used for quite some time to help providers get to the coding piece. where in the future from that is really looking at now, how do we assist the nursing, right? So the rooming, when I told you the rooming of the patient, that can take up to 15 to 20 minutes of the time.
Yeah.
And what you want to be able to do is to use your nurses to be working at the top of their license, not hands-on keys and
Right.
doing that type of documentation. I see a big opportunity in utilizing the note, especially if you have something else that's creating that note for you, to assure that your problem list is updated and what you're going to put on your claim form. Because all you need on a claim form to get it paid, which is what the first part of documentation was, I had to meet all the components of that. But now you also want to get your value based, right? You want to get your risk, you want to assure that you capture all of that. What this artificial intelligence do, you glean that. But from an administrative headache piece, it could also send the right diagnosis codes the first time to the payer, and you don't get information back, and you don't get chart review requests from the payer, so that you have to have resources that are dedicated to that. But if you were able to apply AI to that, then that would be, and it would minimize the opportunity on the payer side to have to do all the background work and the paperwork. So other things they're using is they're enhancing it for clinical decision making.
Okay.
That's a critical piece. And then the automatic extraction of patient data, which is really what they use it for today. But that's just, we just kind of touched the iceberg of that. So there's a lot of work in between.
Good. Now, you did talk about the administrative overhead, as they call it, the provider pajama time. Now, AI can accelerate, addressing that aspect as well. It's not just the accuracy or the quality; it's also the fatigue, which we all are experiencing in the industry today. I mean, we know the fatigue that our caregivers are going through and the attrition that we are seeing because of that fatigue. So, yeah,
from a physician component or from any provider, anybody who's providing services, whether it's a nurse practitioner, whether it's a behavioral health therapist, or that piece of it, there are products out there, and those are the ones that basically are available to groups like Mayo Clinic, people who are using some of the top 5.
Mm-hmm.
However, it's not heavily utilized right now. But really, to stop, they've tried to do some artificial intelligence piece of it to say, okay, if I say this, then you're going to trigger all of this, right? But what they really need is to capture the parts of the conversation that you had and then create the medical record, but also document the piece. And so that's really one of the critical things from a physician's component, that they do not have to, after the visit, so that, like you and I are talking right now, a provider today might have to be turned around, looking here, saying, okay, did I check that mark? And did I link the diagnosis to the right procedure? And oh yes, and then what were you saying about sure?
That's a missed unstructured data input like that.
Right, and so they don't get to, because they're just trying from a component of their physicians. And so from that, really, and I think we somewhat talked about one of the challenges is you really want to educate, right? So if you're going to use AI, you can't just blindly start using AI. Think about the first time, they did certain new procedures.
Right.
If I'm a patient and I go into a surgical room and there's a robotic surgery in there, that's a little scary. So you want to make sure you educate. From a provider perspective, it's like, how is this helping you? You have to pull back the curtain and let them see what's happening behind the scenes and help them understand. So you can do that from an education piece. You can bring somebody in from the outside to really teach and bring AI down to not this little scary science fiction type thing.
Connect the reality with the AI.
Where any repetitive tasks can be done, and really coming down to the point of how can you improve those little outcomes and make it more consumer-centric. So all the patient cares about is having that conversation and feeling connected to their provider.
Yeah, and it should not happen that we bring in the entire machine aspects and kill the human element altogether.
Correct.
That's even more detrimental.
Well, and it's really critical that as you're building things that would help, is for credibility, is having the provider's intake seeing that, understanding when, as we started today, when we talked about EHRs have evolved, and they're really they're the business operations. They do their accounts receivable, they manage millions and billions of dollars of income, and they put that through, and then they're contracting and all of the security type rules that come from that.
I think so we can keep going, but I'll, given the paucity of time, I'll ask the last question on this topic in terms of how can the power of AI, bring in education for providers, because providers may have some inhibitions or a mindset shift is required. How can AI equip that or, enhance that? I know it's going in that direction, but how can AI come to the forefront?
And that's where you have to leverage some of the organizations that have used AI, partners and physicians, but it's really critical to break it down. When value-based contracting came around, there was a huge education process where providers went through 30 to 40 hours worth of actual classroom to understand what a risk adjustment factor is. What was a risk score, and why did it matter whether one patient had a risk score of 1.0 and another had one of 3.49. What did it mean ultimately? Or what it might have meant is you were missing something, and so it helps you guide, it improves the insights. So it's kind of that what's in it for them, because most providers I know and health systems are in it for they want to be the doctor. They want to be able to and the provider.
So as long as we as solution providers and consulting folks, if we can demonstrate the value of that, the power is visible to the providers, and then
what does it mean to them, and how does it impact their patients? And then it's really almost having that focus group of what people know and don't know, and that would be a piece. If I were doing something on how to improve the knowledge, like certain people at one time didn't know what Windows was, right? Yeah. I don't think you'll find a person in the world that doesn't know what Windows is.
I agree. Yes.
Or Word or something to that effect. And so those are types of things. So eventually, we use so many acronyms anyway. So it's first, the word artificial doesn't sound so good to start with, right? So it's like, what are we trying to do? And that's really boiling it down to, we want to take all of that great documentation and then unstructured data. And that's where you tie it back to the SDOH. Because it's been proven that impacts the outcomes of the patient.
Moving on to our last topic in terms of interoperability. Now, we in the healthcare world are in interconnected systems of entities, standard, non-standard, and EDI forms. From a current standard formats like HIPAA, FHIR, HL7, from interoperability perspective, what role can EHRs play, the current EHRs play, so that we can leap onto that stage of interoperability?
Excuse me. Well, EHRs are not actually the thing that's going to make that driving. So it's really their infrastructure and their own interoperability within each one of these organizations, right? So what I mean by that is they have physicians and groups and healthcare as a whole, gets a regulation comes down from the government and said, okay, we've got to make our stuff work like this. Meaningful use requirements where they had to track and do an after visit. So providers wouldn't have done that if it didn't come in, because that's where healthcare basically comes in. And so, as we kind of mentioned, one of the key challenges to that is there are so many different types. And that's why we have the regulations for HIPAA now. Transition codes. So how do we communicate? The one piece that doesn't have a standard is the transitioning of medical records, right? Mm-hmm. So you can capture medical records and you can get you can know what their problem list is, you can know what the outcome was, you can tell what their weight and the blood pressure and maybe some of those key structured data. But from a AI perspective, we're changing that is how can you help define that interoperability. Now, FHIR has done some of that from a perspective of when a patient can access something in HPDI, it's really started on the payer side, where a patient could come and see what claims that have been sent to them, any health plans, any records you have on it. They can basically do that, and they do that through a portal and all behind the scenes, behind the curtain. You know, the API, and there's some standard information that's being associated to that. So it's different HL7, kind of interface, which is what has been used to date. So they do use, that for appointment reminders and some of those other things. But that's the biggest challenge with from an interoperability.
But it's just a step today, correct?
It's a step. Yeah, the step is occurred in the claim processing and anything related to the claim, such as an authorization, such as a request on where's the status of that authorization. So there are about 15 to 20 transaction code sets that are standard for EDI transmission of those.
Right.
That's pretty standard in any EHR. You want to make sure that they can send an 837, which is a claim, and then get that processed to the 835. So.
Now, how does EHR provide data access back to patients using FHIR? I mean, we spoke about
it's not only FHIR that's being used, but they're using some standard API calls, and so they're accessing that data for the most part from on a provider piece through a portal.
Sure.
So they can request from the portal. They can basically look at their records. They can see their lab results. They can see their next appointment, or they can make an appointment. A lot of things they can also send a message, and there are places now based off of requirements where they can request their medical records and they get it provided to them in any format they want. If it's paper, you have to do it. If it's EDI, you have to do it. If you want it on a CD, that's what, it's basically a requirement. But the most part patients want is to be able to basically connect and see their information. But it's not so much their primary care doctor, but if their cardiologist and their neurologist and their hospital is all on a different system, that's where the challenge comes in. Because now that primary care doctor, who's the source, might not know that they already had a CT scan or have that information unless they pull that in.
Now, while patient security is intrinsic and extremely critical, can you touch briefly on this as we cover EHR interoperability aspects?
So that is the why interoperability has been so critical from that component is, and from a patient-centric piece, if I'm treating a patient, patient's interoperability means nothing, right? So as long as they can get access, and so that's the key piece, is giving them access not only to data, but is it accurate and is it complete? That's the really key to get down to. We're giving them insights, whether it's generating, your colonoscopy is due, or you're due for your next appointment, or from that piece. From a provider perspective, some of their EDI challenges are basically the communication between other systems. If they're all within, a lot of physicians that are in large integrated healthcare systems don't have the same problem. Because all their specialists, all their hospitals, all their universe is on the same interoperability. So they don't have issues. Unless that patient, of course, is a snowbird and goes out from Wisconsin to Florida, or something to that effect. But if they are a small group, like we were talking about earlier, that's where there is value for those providers to consider either being hosted by one of the larger groups or utilizing an outside company to kind of help them facilitate some of that EDI.
We have about 5 more minutes left, so I'll just try to wrap it up. One question that I had from an EDI perspective was, EDI is seen as a nuisance, and I'm sorry to use the word in a negative connotation, but for provider group, the way they handle and, from an operations perspective, whether it's claims to AR or, in the current EHR system, what is your view on that?
Well, it's always going to be a nuisance for the provider, and so what we try to do on the administrative side and in operations is you try to remove some of that from the provider. So the provider, and that's the whole purpose of the EHR. So the EHR is truly a tool for them. But when they're asked to make sure that they check off these 15 boxes because it has to be sent and it's a requirement, or I have to basically track and see whether or not I have to document that the patient's smoking or not smoking, or just things like that. So it's a nuisance from the perspective that they are requirements that they have to do. They have to make sure they have the care plan, they have the goals set up and pieces, and they talk about it all, but then they got to make sure it's all documented and sent. But their biggest EDI needs is what I talked about a little bit earlier, and that's just making sure that they have access to all the data and information on that patient that they're seeing. Especially if you're a specialist, you need to make sure you get all the primary care notes and that you communicate back to that primary care doctor because it's their patient.
I think so. We are almost on time. You gave us a lot of valuable information. We can keep going on and on. Hopefully, we'll find another occasion to connect again and do another session on one of these topics as a whole topic by itself. So we'll try to find time and an opportunity. But Rosalind, you've been wonderful. You have been kind and gracious. Thank you so much for your time. You have a wealth of information. We really cherish that. Connecting with you and going through this webinar. My team, my partners, my prospects are definitely going to benefit. And I see this as a lot of value add between us. Thank you so much for your time. We appreciate it, and good luck to you.
Thank you very much. It was my pleasure. I learned a few things as I did some research as well. So.
Yes. I really appreciate it.
Thank you so much.
You have a nice day. And
thank you.
Yes, thank you.